an outpatient dietitian. I wanted to introduce myself. So I've worked in primary care for a few years now, been a dietitian since 2019. But this topic has stood out to me more recently, primarily because when I work with adult patients, I can see like across the lifespan, even decades before, some of the early feeding practices and experiences with food and all the social determinants and how that affects health later on in life. So when we're considering the whole person and everything that is involved in being able to come up with a plan of care that's patient-centered, I definitely have a newer interest now in early intervention as possible and working with um, moms, families, and just coming up with a team approach, more integrated care. So I had to start with a conflict of interest statement. So no relationships to disclose, commercial products or services. And then the objectives would be we're going to start with talking about some of the positive and negative feeding practices, some of the educational information that we can provide for caregivers and support them. As I was looking through a lot of research studies, that was one of the top interventions that can be really helpful and is needed with caregivers and just feeling like they need additional support, such as breastfeeding education. And so there's going to be a lot of recommendations or resources in the presentation that anyone can return back to. Make sure that the slides are accessible as well. Everything evidence-based and also stuff that we can share with our patients as well. Just a lot of this has come from just listening to patients and their questions and concerns and kind of identifying or finding resources along the way. And then with nutrition interventions across the lifespan, we have to adapt our education or provide intervention, really identifying what the cause of the concern is or the cause of their, whether it's malnutrition related or if it's more about the family and their meal planning. So we'll talk about that and how to identify what resources are appropriate and what conversations to start with family. The second part, identifying nutritional needs and concerns. So there's just different ways that you can do screening. And so as a dietitian, our process is doing a full nutrition assessment, the initial nutrition assessment. And then we provide a nutrition diagnosis, and then that follows with interventions and then what we want to monitor and evaluate as we continue providing care. And then I'll talk about the prevalence of obesity and some of the associated complications in youth. Proper nutrition counseling strategies, and the nutrition counseling, it can be for patients who have had disordered eating patterns. It can be for pediatric weight management. It can even be with just counseling families on healthier eating, just general nutrition counseling. So a lot of motivational interviewing and other skills to be able to help the patient identify what matters most to them. And then tailoring it to their stage of change, like whether or not they're ready to make those changes. And then defining pediatric malnutrition and eating disorders. So, I didn't talk too much on my background, but just basically I'm seeing patients who have, well, across the lifespan, so it could be anywhere from neonate to geriatric, but I have been working with patients in rural Oregon as well, and that's a very low resource setting. So it definitely has helped me to better understand, again, adverse childhood experiences, anything that can impact a child's development. And then as adults, working with them and being able to come up with a lot of behavior change strategies that are really specifically focused to their needs and their readiness at the time. But yes, we're focusing today on the earliest ages. So to start, I wanted to start with the feeding practices part because I've noticed that this has a really big impact on how kids regulate their energy intake. So early on, infants and young children are able to self-regulate. They respond to those internal signals. But the response that they have to food is also shaped with their environment. So it's not just what foods they're fed, but also meal patterns, right? Routines and then what foods are available. So the next part kind of breaks down, especially with food insecurity and how feeding to soothe was a long time ago. I'm talking like back when food was really scarce for a lot of people. That was developed initially. And so that it was in response to not having food always available. So naturally, parents would use that as a way to soothe their kids who were, if you think about what may be contributing to some of the behavioral problems or not being in an environment where food was as plentiful. So that was considered or can be considered non-responsive feeding. The caregivers may not be as sensitive to the infant's cues. And so non-responsive feeding, and I'm not going to go too much into the responsive feeding ones, but can kind of compare and contrast there. So non-responsive feeding would include food is the first response when parents see their kids distressed or crying, feeding frequently with portions that are larger than what's necessary at that life stage, right? So it depends on their age. Offering children their preferred foods. The biggest one that I've noticed that carries on later into teenagers and adulthood is when foods are restricted or controlled, or when kids are pressured to eat what is given to them. So the pressuring and restricting has a big impact. And those were just observations that I've had from talking with patients. But then when I went back to research studies and really dug into that, it was reflective of that as well. And I'll talk about that a little bit later on, but there's references to the research studies. There's one that is really good and goes in depth that I recommend. That's on the next slide. Definitely if foods are used as reward or withheld as punishment. I think a direct quote from patient in the past was when a parent had withheld food as a punishment and just the effects that that had on her even later on in life. So yes, decades before. So this can, again, with the presence of food insecurity, and I'm sure those listening have an idea of how the prevalence of food insecurity is striking, considering how much access to food we have in America. It's a very prevalent problem. And so when there's food insecurity, and then in addition to that, there's excess food available, that's what can make it even more of a health risk, especially for obesity and those complications. Parents who rely on their own hunger and satiety cues when they're eating and they practice intuitive eating, they're more likely to feed their infants in a responsive style. So working with parents as well. And that's something I'll bring up a little bit later, but definitely being able to invite those conversations with parents as well about their eating habits. And if there's not regular meal times or patterns, asking questions about trying to explore the reasons why. And again, if somebody has over time just ignored that internal, or maybe they didn't develop it when they were a kid, right? So if they've lost that intuitive signaling, which we can talk a little bit about that with the eating disorders, but then a parent would need some additional support and counseling as well about how that you can develop that responsive feeding style. Okay. So this is one of the research studies that is just really helpful for guiding nutrition interventions. It's a very important one that's had years of research. So just feeding infants and toddlers, the latest one in 2016, we used dietary recalls for anything like the NHANES data as well. It's pretty standard. So you would go through, and I do recommend as providers, any healthcare providers can definitely use this with their patients. So dietitians will just ask our patients what they had to eat in the previous 24 hours. And then we'll usually go through it once or twice again, depending on how much time we have, to try to get an idea of the portion sizes and how much they actually consumed, any beverages they had added, things they added to when they were cooking the meal. So some of the things that stood out, there will be more on the next slide, but just the targets compared to, or what our goals are for breastfeeding and where we're at. There's been improvement overall, but definitely haven't been able to meet that target. And then it compares the different populations that if we're looking at any places that we could provide more culturally appropriate education. That's something to consider too when we're looking at this data. And then just thinking of what are the barriers to it, right? Better understanding where they're coming from. And I know that my aunt is a doula, and when we've talked about it before, it's just one of those things that we're aware of is when moms go back to work so quickly, right? So if they're trying to be able to follow these recommendations or other reasons. So there's some resources provided in here. There wasn't enough time today to talk about the benefits of breast milk or on cognitive and brain development or any of the immune system, but definitely a topic that you can, there's some resources in there for supporting patients with breastfeeding. And then the last part was just what they're eating when the complementary foods are introduced. This one doesn't include I think the dairies on the side. It should tell you a little bit more about, yeah, just consumption at different ages. So, and then one of the things that affects complementary feeding is whether or not they're breastfed or formula fed. So the timing of that typically and when it's introduced compared to when it's recommended, between 4 to 6 months. I think that there was a change so that I believe that it's recommended now to introduce the foods that aren't as sweet first, and then sweeter foods like fruits a little bit later compared to what was suggested in the past. And there's a brief mention of that later on about with toddlers' eating behaviors and how their preferences for certain flavors like sweet and salty over bitter, sour and stuff. So that's one of the reasons we would start thinking about which foods to introduce first. This one just talks about areas for improvement. So the ones that we would be wanting to talk with our patients about, just for making sure that we're helping with the prevention side of things. So which foods are good sources of iron, which ones are good sources of even folate if it's like green vegetables. And so those are some of the targets that fall short. Sodium, where the sodium content of foods. I think, so for the sweet foods on any given day, and then there's definitely guidance around added sugars and limiting those. And then the cow's milk, so 1 to 3-year-olds don't drink cow's milk. There's a slide that talks about vitamin D intake later on and how vitamin D deficiency is a significant area for improvement in the diet, and just early on the effects that it could have. So that's one of the things to consider. And then as more mothers are breastfeeding, that's great. The whole grains are increasing as well. I think there's a little more awareness around difference between just some foods that are more highly processed and and some creative ways to incorporate more whole grains into kids' diets. And then there has been a reduction in fruit juice intake, which is good as well. 25% of toddlers' calories comes from snacking occasions. That's something to consider as well, counseling on what kind of healthy snack options to keep on hand and how much time in between meals and snacks is appropriate. And then I did put my summary or my observation in there that the nutrition impact or the nutrition interventions, if we're counseling on what foods infants and toddlers should be eating, it's highly unlikely that will change unless their parents change what they're eating as well. So that's just one of the conversations to open up about healthy food choices, getting the whole family involved when we can, and having them involved in the entire visit. Um, Risk factors for feeding complications in toddlers. So earlier I was kind of describing the introducing foods, the complementary foods, and a risk factor would be if they're starting to have fear of the new flavors or what is accepted more quickly. The social interactions during mealtime, and one of my favorite websites, it's mentioned later on, but the Family Dinner Project is really great to reference as well. The reduction in their hunger and satiety awareness as well. And so if there's any of these signs or symptoms that parents are bringing up, then we can start early intervention as early as possible is the goal here. Just that it's typical for toddlers to start having picky eating. So reassuring parents that it is typical of that age and life stage. And then if there is pressuring to eat healthy foods, that can promote more of a dislike for those foods, as mentioned earlier. So the recommended reading, it talks about, there's a really in-depth review of the barriers and enablers to caregivers' responsive feeding behavior. So I mentioned one of them was that would be a barrier is not having education, not having as much support as maybe is needed from healthcare providers or even from family members. There's plenty of other things mentioned in there that could be including social determinants. And then if we have a better idea of what some of those barriers are, and then the enablers are the ones that we want to try to encourage as well, that will help support the caregiver's responsive feeding. And then some of the other ones are medical risk factors that, so if there's anything in their medical history, if they had really early feeding difficulties, I usually ask patients if what their gestational age was, if they were premature, and birth rank and family is one that's in there as well. If there was or wasn't exclusive breastfeeding early in life, when the solids were introduced. And then, just talking a little bit about their feeding practices early on, what texture variety did they have? I don't spend as much time talking about that when they're already in toddlerhood because they're past that stage, but it does help get, again, when we're thinking about the entire life course and model and what interventions would be best, then it does help to have a snapshot of the infant's history or the toddler's history. And then if there's anything else that was significant in their medical history, definitely anything gastrointestinal. If dietitians will get referrals for pediatric patients who may have had a history of cystic fibrosis or cerebral palsy. So if there's definitely any neurodevelopmental conditions, osteopathic, something that might impact their ability to properly eat well and have meet those developmental milestones for feeding. And then maternal history too. So talking about any mental health concerns, right? So any signs or symptoms of potential disordered eating. Okay. So some of the tips for, this is mostly for selective eating, but it's really helpful too when it does reach into feeding disorder, but that's different. That would be usually an external referral where they can get a full feeding assessment. So just general eating behavior disorder where the pickiness or selective eating is potentially creating a risk for their nutritional status. So some of the tips would be just, I'll start with the ones on the right. Serving age appropriate portions, so education on what serving sizes are appropriate for their age. Love getting kids involved, and it's really it seems simple but tried and true approach to have kids just participate in the menu planning and being able to have every single sensation when they're involved in the eating meal planning process. So whatever they can do with cooking, sitting with children at meals and snacks, again, seems simple, but these are things that when parents have a busy lifestyle and And kids do as well these days. So definitely trying to emphasize the benefits of that and just seeing again, actually asking the questions so that parents can start noting what they're observing at meal times with their kids and how they're talking about foods with their kids. So planning family meals, avoiding the power struggle with toddlers, definitely having them participate, even letting them choose from a variety of foods and pick what's on their plate. Um, not labeling and overall, not talking about weight, not talking about foods as good or bad. Um, I love this one. This is my favorite. Building on the positives as they occur. We talk so much about what maybe to avoid, but parents are hard on themselves too. And so trying to have them really reflect and think about the positives so that they can build on that. So there's a case study later on that I'll try to talk a little bit on how that was impactful for the parent. Okay. And then just, yeah, definitely one of the biggest things is just trying to be patient and expose regularly a lot of times until they're really comfortable with the new food. Not bribing, not grazing in between meal times. There should be some bottom line limits, positive role modeling, and again, emphasizing that it will take time. On the left, it's too much to read through, but I did want to just touch on the highlights. So the feeding relationship, there's definitely evidence-based information that would be helpful to provide for parents, but I usually start by asking more about what's their feeding style. Are the parents on the same page? Who else is involved? Are their grandparents involved? Is there a babysitter, nanny? So what is the feeding environment like? And as best as possible, trying to have consistency. Um, and then keeping it neutral, not really stressful topics around eating or even at meal times. So that routine encourages appetite. I always ask about beverage consumption with kids who have really selective eating behavior, so that you can get an idea of, are they filling up on their fluids, or is it really just lack of appetite or something else going on? Referrals are really important. I tend to see kids who have a lot of complex behavioral problems going on, and gastrointestinal. And then if there is delayed growth or if it's impacting their development in some way, then we would refer out. Malnutrition depends on how severe and whether or not how well the kid is eating. And then if there's oral or motor difficulties, and if they need like help with speech language pathology. Division of responsibility, I think I bring that up later on. So Ellen Satter Institute is a great resource. The family meals brought that up. Exposure routinely without pressure. And then screening their diet. So making sure that there's inclusion of enough iron-rich foods, at least 3 servings of calcium-rich foods per day. If a child is underweight and has trouble gaining weight, we usually talk about foods that are really energy dense, or smoothies, high calorie smoothies. Those work really well with kids. If they have a color preference, if it's a kid with autism and they have a favorite color, just make the smoothie that color and avoid the other ones. But still, you can provide enough nutrients in a smoothie as well to make it a balanced meal. But yeah, mostly the high fat foods. And then for kids who are overweight, this sounds counterintuitive. Maybe in the past, when weight management with nutrition interventions a long time ago would look a little bit different, really focusing on the energy density of foods. But another approach that is definitely important to consider is kids definitely need the extra energy, right, as they're growing, including them with meals, because they're more likely to provide that satiety as well. So, and then I threw in there a note, just supporting a healthy body image, not talking about weight or dieting. Yeah, so just as minimal exposure as possible to diet talk, because that can rebound later on in life. Okay, just the first 1,000 days, and I was talking about how important nutrition is for brain development. And then, so these are some of the impacts that we know that nutrition impacts behavior. And then if they're provided, if there's a child gets adequate nourishment and the mom as well during pregnancy and during lactation. And then, so the nutrients that are necessary for kids' development, this will impact their behavior, their brain development, and iron status is a big part of that as well. Their immune function, their gastrointestinal function. We know a lot more now about the microbiome and the effects that has on health later on in life. So, but that also, if it's impacting, if we're thinking of the whole person as well, then we know that that's nutrition is impacting their mental health and their behavior, and then that interaction with others and better interaction with their caregivers and their environment will help support their nutrition as well. So I just put that there as just that cycle that can happen if they're malnutrition is a cycle, and poverty as well, and other things to consider if someone needs additional support. That an early intervention just hits every mark when we think of a kid's health and their risk for diseases later on in life. Obviously, there's other things too, like genetics and other things that we can't always control, but okay. This is just sorry, that slide's a little blurry, but just a timeline to show from infant to toddler nutrition. So at birth, the vitamin D supplementation, and I provide a resource at the bottom you can look at, and then the slide on vitamin D later on it has the recommendations for supplementation on there. Okay, and then the first 6 months of life, exclusive breastfeeding is recommended. I think I'll touch on just a couple benefits in a minute and how that's tied with reduced risk for obesity and other things as well. Okay, and then for 4 to 6 months of age, trying to introduce those potentially allergenic foods, the complementary foods as we talked about. There's a slide that will talk about baby-led weaning really briefly. And then at 4 to 6 months of age, the iron supplementation will be recommended if the baby's still breastfed. Until those, and then we can start counseling though on the iron-rich foods and introducing those. And that's the highest, the iron deficiency is the most common. And it's also really common between 1 to 3 years of age. I'll show that statistic later. Okay, and then just when they transition to dairy milk, and then it talks about fats as well, because there's been some confusion around that. Okay. And then beverages later on. There's a resource later on that's great for if you're looking at something to break down the beverage recommendations. For protein intake, breast milk has 5% of the energy from protein. In formulas, 7 to 10% of energy is from protein. And then that graph on the right just shows how there's a difference in growth. And certainly when a kid is breastfed, they'll maintain a healthy growth curve, but be at a lower body weight. And then just the idea of like when it's important to provide formulas, what type of formulas, how that helps with faster growth, or then the primary source of protein for toddlers. So if we're talking about later on, cow's milk or dairy provides a lot of that protein, but it doesn't have as much volume. Okay, and then just the reason it was brought up is that the research around higher protein intake indicates too that it'll increase insulin levels, and just so when later on in life, it may have an effect on obesity. And but the key that I wanted to highlight was, or observe here, is that even if baby is formula fed, how they're fed matters as well. So just those who are breastfed, if it's the pumped breast milk, and then they're using the bottle as well, that will also impact their appetite regulation later on in infancy. So what babies are fed and how they're fed matters. Okay. Complementary feeding. So here it just talks about just, yeah, when we're looking at what's developing still, and then the timing of why we wait for introducing foods. So waiting until their digestive tract, immune system, oral motor skills are sufficiently developed to handle those foods. And then the difference if a baby's premature. And so those who have, and disclaimer for me would be that um, I didn't have practice experience specifically in pediatrics, although I do get referrals um, for to provide care for kids and nutrition interventions, but usually we would have a pediatrician provide this education and to help support families with the timeliness of feeding and work with them. Um, but I did provide some basic introduction to it in here. So some of the benefits of baby-led weaning would help with reducing food fussiness, higher food enjoyment, improve responsiveness to their hunger and satiety skills, and energy regulation, so weight management. And then it also helps with the caregiver because there will be less stress. Overfeeding may help with having a wider diet, more variety in the diet, and then the motor skill development. The concerns in research studies just showed that there could be a choking risk if they're not really developmentally ready, but it's not clearly summarized in the literature. Another concern would be if they're introducing foods that are already in the family's diet, what is the family eating? What's the quality of the foods? Are they healthy? And then what are are they getting enough of the nutrients that are needed for their growth? What are they feeding their kids? Okay. This is more of again, something to reference later on, but just some of the nutrition interventions. Healthful diet definitely needs to increase some of the calories and protein needs for lactation that's required. The nutrients that were depleted during pregnancy, making sure that the mom gets the adequate vitamin and mineral supplements. Yeah, and then I did want to note that I think I've had moms who are breastfeeding be concerned that, or tell me that they're concerned that their milk supply could stop if they're not eating enough. I do think that it's important to make sure that they're eating regular meals and snacks and talking about calorie and protein needs, but there's a lot of other factors too. So just making sure that the mom doesn't put it all on um, one thing. But yeah, it doesn't guarantee the supply of milk. But it's very important, the health of the parent and the nutrients that are available. In infancy, just yeah, helping with the amount breast milk or formula. So we'll do the calculations of what their nutritional needs are and provide guidance around that. And as I mentioned, just having the pediatrician work with them on if their developmental signs and their readiness to begin. And that's yeah, just a team approach too. So we're a resource for you, dietitians are, if you have patients who are in need of some information on their nutritional needs. And then the fluoride supplementation, if they're not formula fed, and then parents, caregivers, how to achieve growth goals with that feeding plan. Toddlers, general healthful diet, and the establishing regular meal and snack patterns and supporting the toddler's acceptance of many variety of foods as possible. Yep, and then just what to look out for with hunger and fullness cues. And then in preschool, starts slowing down with their growth velocity, just looking at are they meeting those targets for development, their increased independence, autonomy, and then the caregivers like ability to be able to identify those cues and the sensitivity to them. But I think the main thing to focus on is just what lifelong eating habits look like and starting to establish those early on. I did recommend here the Ellen Satter's model of the division of responsibility. Caregivers are responsible for what foods are offered and when, and then where as well. And then the child decides how much food or what they eat, so whether they're going to or not. School age, So starting to establish the physical activity patterns as well, and healthful eating and stuff that would help prevent more immediate health risks. Iron deficiency is later on, undernutrition. Adolescence would be making sure that they have enough of the nutrients to meet their growth. And then the micronutrients even as well when their bones are growing and their muscle mass. So just there's a lot specific to each life stage. And so there's um, individual nutrients of concern that we would talk about, like calcium and vitamin D in adolescence, even though that's important for all ages. They're working with the teens to help them to identify what foods will really support um, their needs and their growth. And then healthy eating habits. And for young athletes, that's my favorite population to work with in pediatrics. Just I have a background in sports and nutrition, so really fun to work with them on meal plans that are specifically tailored for their performance needs, their timing, their recovery, huge on recovery, getting enough sleep, being able to properly fuel their workout, hydration, it's huge. They're needing to be able to get enough fluids to replete what's lost. And then educating not just the athlete, but also parents. And even I've worked with sports staff as well. And we've had to reach out to um, if I've had like athletes who have celiac disease, so they need help from the school to make sure they're getting enough, or if their parent sends food with them. Another young athlete had Crohn's disease, so he was on a special carbohydrate diet, and I had to counsel him on trying to get more starchy vegetables. And even though that diet was eliminating so many carbs, he was a runner. So yeah, just identifying what gaps we can fill and help them have the best quality of life. Prevalence of obesity is still increasing. I did include a really recent, the study just came out in March, but since I'm from the Bay Area, I wanted to highlight that. In the study, um, I think there's just over 100 participants with limited income, and it had looked at the association between food insecurity early on, like around age 4, and the increased risk for fatty liver disease. Um, and the reason I brought that up was we're doing a healthy kids camp with the YMCA with UC Davis, and that yeah, just trying to it really showed how important it is to have that screening as early as possible. So for kids who are um, um, overweight or obese, or even have other risk factors, that being able to um, detect that early on so we can address it if they're at risk for fatty liver disease, and making sure that we're screening for food security status too. It's a really easy, quick screening to do with patients. Some of the complications, pulmonary, and we see a lot of asthma, sleep apnea, I see that more in teenagers, and then cardiovascular. So I get referrals for the lipid abnormalities. There's high blood pressure. For gastrointestinal, we definitely see heartburn symptoms, constipation. I put the fatty liver disease in there as well. Type 2 diabetes is still increasing in youth as well. So impaired glucose metabolism, insulin resistance, PCOS, the symptoms to look out for on there. Okay. And then for psychiatric, there's a higher likelihood of obesity, or I would say the strong association, let's put it that way, between anxiety and depression, eating disorders, and adverse childhood experiences. Okay. So this is a great resource here. I'm sure most providers in their medical school have done motivational interviewing classes. It's really helpful to assess where the patient's at and their readiness for change. So that's the different stages of change. And then the counseling objectives are followed by that. So it's just what is appropriate at that stage. So if they're not even contemplating it yet. This is typically with teenagers, that's where they're at. They're in the pre-contemplation. Anytime they're referred to me, they're not even really thinking about their health at that time. So just accepting where they're at, starting to build that rapport, create a supportive environment. Definitely, if we can get to that point where they feel comfortable and build that relationship, then they're able to express their emotions more, or just how they feel about food, their perception of their own health. What have they heard about health and the messaging? And then their knowledge of nutrition, assessing that, their motivation to change. Okay, and then so just awareness, like starting to build that awareness of why it might be important to change. Okay, and then there's different stages, and then if they are taking action on something, and this would be ideally a whole family getting involved when we're doing pediatric weight management. Um, so it would be working with the parents and seeing their readiness level as well to change. Um, okay, and then so as we express empathy, we can also try to determine if there's a discrepancy between them wanting to change and where they're actually at, or if they don't believe they can change. So kind of one of the things that I've started asking more is what strategies do my patients really think would help them? What has worked in the past? The client is in control. They're choosing their own goals, the short term, the long term. But there's a lot of different tools that might work. With teenagers, you can try doing contracting, self-monitoring tools. May or may not, they may or may not find that to be beneficial or helpful. Controlling what's in the food environment. So again, the family is still in charge of what foods are offered, even though they have a lot of independence there. Yeah, and then if it is self-image concerns, or if there's something that if they're demotivating themselves by having those negative thoughts or negative talk, you can find ways to, and you can refer to behavioral health for that too. I do that often. Okay. Iron deficiency. So this is something I'm pretty passionate about, just because all of my clients have been in the high risk group, lower socioeconomic status, poor maternal iron status. There's a lot of medical conditions that can cause iron deficiency anemia. But for babies, that was something I wanted to introduce. With infants who are transitioning, we know that like the American Academy of Pediatrics recommends waiting primarily for that reason, that there could be like cow's milk is associated with low iron as well. So there's some other things to consider. Definitely adolescent girls, if they're depending on what their menstrual cycle looks like. Athletes, really common, and I have had one or two athletes with disordered eating and have had their periods go away. So that's a sign of the female athlete triad. And then illnesses, if they're losing iron, I've had patients who've had blood in their stools from a type of gastrointestinal condition. So yeah, just some of that can contribute. Malabsorption. Okay. And the prevalence in developed countries is pretty high, considering that we have access to there's plenty of iron-rich foods in the diet. All right. Bone mass. So vitamin D intake in pregnancy supports that's what I just wanted to make sure that I touched on why it's so important. The fetal skeletal system, tooth enamel, calcium regulation, immune system, their neurodevelopment, and then also the reduced risk for adverse neonatal outcomes as well during pregnancy. When the bone mineralization in utero, when it's at its peak, 2/3 in the third trimester, and then just during adolescence again. And then, yeah, that statistic I promised, vitamin D intake is inadequate in more than 75% of children 1 to 3 years old. Okay, there's just not a lot of foods in the diet that are really good sources of vitamin D, and there's definitely a growing amount of people consuming plant-based milks and eating more plant-based. So just, yeah, having those conversations around what are alternative sources of it, and then supplementation. It's really common. Lots of conditions that are associated with reduced bone mass. I brought up a few earlier. Some of the gastrointestinal conditions where there's reduced absorption. If there is renal disease too, if there's eating disorders, some of the endocrine conditions, just obesity overall. I've seen vitamin D inadequacy just with that alone. There's a couple of providers who won't even order those labs anymore just because they assume and that's in Oregon. So I mean there's less sunlight there too. So there's other reasons, but and what medications they're on. So thinking of all of the um, risk factors for not just vitamin D deficiency, but also potential reduced bone mass and early intervention again, so that can support healthy bone density throughout life. Malnutrition. So we use specific criteria to diagnose, dietitians do. We have for adults, and then in pediatrics, there's the growth indices, growth pattern indices. So I like using, there's a website called PD Tools, and I use those growth charts and calculators. Acute undernutrition would be when just the weight alone decreases, but their height is preserved. So and then the chronic undernutrition, which really don't see, I mean, failure to thrive is listed down there. But I only saw that in underdeveloped countries and with the stunting and just the significant effects. And there's a lot of added nutrition required to help with the catch-up growth at that point. But the effects of malnutrition, I did want to make sure that was in there as well, just how it can affect behavior, the cognitive function. I ask parents how often their kids get sick a lot of the time, just so that we're starting to get the full picture of their nutritional status. We do a nutrition-focused physical exam. That's not included in here, but we'll look for any signs or symptoms of nutrient deficiencies, like if there's excess hair loss or brittle nails, any rashes. I've had, so if a child has signs that they could have celiac disease, for example, there's going to be a lot of possible signs or symptoms. So being pretty thorough on that when we can. This topic, so eating disorders, this really just screening is what providers can do. Having a list of some screening tools. There's the SCOFF is like 4 or 5 questions, and then there's just so many aspects that can contribute to disordered relationships with food and the body. They affect people, everybody. So I just wanted to make sure there's a lot of stigmas around eating disorders and when a patient may need treatment. Or I would say like it's more of just there's misinformation or myths out there just for the general public, but even just like when to have a conversation and what signs or symptoms there are. So yeah, it's a passionate topic I'm passionate about. And there's a couple slides here. I'll just kind of run through it, but the statistics always are shocking. So 42% of 1st through 3rd grade girls want to be thinner. 81% of 10-year-old children are afraid of being fat or even being called that, which they're often bullied as well. 46% of 9 to 11-year-olds are sometimes or very often on diets. And then it starts getting even more prevalent as females and males to get older. So there's the trying of crash diets, and then the compensatory behaviors. And then in a college campus survey, one of them, there was just over 90% of women who controlled their weight through dieting. But overall, just as an intervention that we can all take into account, if we notice that, if we ask our patients about their eating habits, and then any, if they're uncomfortable even getting their weight checked, just something that is an indicator that it could be negatively impacting their quality of life. So early on, those what messages we share about health, it can be associated with psychological distress and even higher risk of unhealthy eating behaviors later on in life. So, and then I pulled on another study that I found that just came out as well in the Lancet Child and Adolescent Health. So the higher food responsiveness in early childhood is also associated with eating disorder symptoms. So when we're talking about the feeding practices early on, it's not just with obesity, but also eating disorder symptoms and how if there's later on in life, they may be more likely to restrain eating, and then that can lead to binge eating, uncontrolled eating. Yeah, so this all ties in, it all comes together. These are just signs or symptoms of the three main ones, but one of my case studies is actually on another eating disorder. It's on ARFID, but these are ones to consider with definitely like with binge eating disorder, we tend to see more depression and anxiety. It usually would be more associated with overweight. And then just the different, when we're doing the full physical exam, and at any time there's a suspected disordered eating, it's really good to be thorough on the physical exam part. So I think there's a part on the next slide. Yeah, so gastrointestinal issues are that's the biggest association that I've observed. If I've had patients um, who are referred for gastrointestinal conditions like irritable bowel syndrome, they may actually have disordered eating that's contributing to that, or if their IBS is causing fear of eating foods, and especially when it's really severe and anything they eat causes having to run to the bathroom, it's causing a really poor eating habits. So that just makes that cycle continue. But the structured meal plans really help the body adjust and to eating and digesting foods again. I did have a dietitian who specializes in eating disorders look over these slides as well. But there are things to consider just with when we do refer patients in for eating disorder treatment. If they're only managed on outpatient treatment, maybe they already received inpatient and then they're following up with primary care. So we wouldn't necessarily have to look at monitoring their electrolytes. If they do have bulimia nervosa, then we would still want to monitor, like order CMP every now and then. But yeah, this is more for what's the labs that are done in the inpatient setting. Yeah, and then so just what are the warning signs, and then if there's food related fears ongoing, how can we counsel patients towards just what resources would be necessary. So there's a couple treatment manuals in here just as a good reference for as a guide for what nutritional treatment would look like and the different evidence-based interventions that are available or recommended. Here's various tools: the Academy of Breastfeeding Medicine, the Womanly Art of Breastfeeding book. I think they're rewriting that, but it's a great resource that was written by parents, moms. The DRI calculator is just there for you if you want to use that. And then medical calculators, I mentioned that one. The Feeding Matters Infant and Child Feeding Questionnaire is one of my favorites to use. It's very comprehensive. There's some screening tools in there, and then the Healthy Drinks, Healthy Kids for beverage recommendations. Okay, well, thank you so much for letting me present today, and then just that my contact information is on there as well. Again, really a topic that's more of near interest to me, and we dietitians welcome referrals to help support you as well. We're a resource for you and your patients if they have questions. Thank you.